Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual, and today some more important clinical care tips that hopefully help you take better care of your patients. Rule number 153. Address the issues or chief complaints like an ED doctor. So this is something that I often find myself tell the pediatric or the family medicine residents I work with, simply because those residents often think like diagnosticians, and it's important for me to teach them that they have to adopt the non-diagnostician mantra that we use in the pediatric emergency department. Let me explain. As an emergency physician, I really see myself as having two goals or two tasks for every patient. Number one, I always have to provide acute care. Maybe it's CPR because the patient is unstable, maybe it's just Motrin, maybe it's fluids, maybe it's PO fluids, etc. But every patient and every chief complaint has a certain need, acute need, that needs to be addressed. The second thing I have to do for each patient is to decide on the appropriate disposition. Is this abdominal pain, rash, or whatever the chief complaint is something serious, surgical, for which the patient has to stay in the hospital? Or is this some benign condition for which the patient can go home and follow up with his or her primary care? Somewhere in the middle, very often, but not always, I'm engaged in some kind of workup, maybe X-ray, maybe labs, maybe even CT, that will help me decide on the appropriate disposition. But essentially, it goes back to the same two things I have to do for every patient. As a pediatric emergency doctor, I do not see myself as a diagnostician. I've spoken about it before in the podcast, and I stress that approach to the resident every time. I am not in the business of pinpointing the diagnosis. I'm not in the business of telling the parents exactly what's going on today. Maybe I can, maybe I cannot, and some parents have a hard time hearing that, but it's the truth. I am not a very big knowledgeable person on abdominal pain for 8 months. I don't take care of chronic conditions. I don't really know the etiologies for most chronic conditions, and I have to be honest about it. So when the patient presents with, let's say, abdominal pain for 7 months with no red flags and a physical exam and the history is reassuring, I really have no idea why he or she are having abdominal pain. There must be 20 or 30 or 50 or 100 possibilities or etiologies for chronic abdominal pain that I, as an emergency physician, don't take care of and don't know much about. That is why I tell the residents, when you see the patient and hear the chief complaint, you gotta address it as an emergency physician. Number one, give the patient what they need right now. Number two, be honest with yourself, decide on the appropriate disposition, and understand that you may not know the etiology for the abdominal pain, the rash, or whatever the chief complaint is. However, if you address it like an emergency doctor, you as a physician will have a much better experience and likely you will do the right thing for the patient. The way I recommend doing that is with what I call the red flag theory. Listen to the HPI, do your physical exam, look for any red flags in both, and if there aren't any, provide reassurance and send the patient home. You, as an emergency physician, cannot possibly know all the newborn rashes that are out there. There are 20 of them, however, they're all benign, they all go away, and there's no treatment for them. You don't need to know what they are, but you must know that this newborn with a rash in front of you does not have herpes, does not have Stevens-Johnson syndrome, does not have any serious or life-threatening condition. You do that by recognizing that there's no red flags. The rash is not vesicular, the patient is not ill-appearing, it's not petechia or purpura, there are no mucous membrane involvement, etc. And this is something that most of us do, maybe even subconsciously, specifically with abdominal pain. When we see a patient with abdominal pain, we often ask about right lower quadrant. We often check for peritoneal signs and document that there aren't any. I think many of us know very well the red flags for abdominal pain. The same way, I recommend you address all your patients. Look for, ask for red flags, and if there aren't any, provide reassurance and send the patient to the appropriate outpatient workup. So remember rule number 153. Address the issues like an ED doctor. Don't think of yourself as a diagnostician, just focus on providing acute care and deciding on the appropriate disposition. Rule number 154. Pinpoint the syndrome if you can. So in the pediatric emergency department, oftentimes I see patients with many different kinds of syndromes, many of which I learned about when I was a general pediatric resident, but again, as a pediatric emergency physician who is now further removed from general pediatrics, with time, I forgot many of them. However, as a pediatric emergency provider, I must know what are the possible worsening, or if there is any possible worsening for the patient in front of me. So when I see a patient with dysmorphic features and significant past medical history, I often ask the parents, do they know what kind of specific syndrome he or she has? The reason is because many syndromes come with specific concerns. For example, patients with Noonan syndrome have pyloric stenosis. So if I see a patient with Noonan syndrome with difficulty breathing of acute onset, I must think about worsening pulmonary stenosis, maybe get an echo, speak to cardiology. I have to worry about a heart failure. In a patient with Potter syndrome that often have UTI, I need to know that they often have UTI, and if they present with fever, check the urine, maybe worry about pyelonephritis, admit for antibiotics, etc. Patient with Shwachman-Diamond syndrome with fever, I have to worry about a serious illness simply because Shwachman-Diamond syndrome is a combination of immunodeficiency with pancreatic insufficiency. That is something I need to know. So if a patient with Shwachman-Diamond syndrome presents with diarrhea, weight loss, I must think about pancreatic insufficiency that may have gotten worse and speak maybe to the GI doctor. So it's important to pinpoint the syndrome if you can and worry about what specific complications that patient may have. Now, this is not something that needs to be memorized. Luckily, we all have access to a lot of data on the internet, up to date and whatever. So if you can, ask the parents, look up the syndrome and look up what are the possible worsening for that child. Address those needs. Make sure you rule out any serious possible emergencies related to that syndrome. Maybe speak to the appropriate specialist and do the right thing for the patient. So remember rule number 154. Pinpoint the syndrome if you can. Rule number 155. Adjust your care to the patient. So this is, I think, a rule you learn with time as you practice medicine, especially as an attending who carries the biggest responsibility for the patient, and especially when you decide on the appropriate disposition. This rule is basically the core behind the saying, medicine is an art, not a science. Again, always a good idea to give an example. So every once in a while, I see patients that come from out of town, they're on vacation, the child had some kind of injury or has some kind of chief complaint, and I have to keep in mind that family does not have a primary care in town. Under those circumstances, it's in the patient's best interest to possibly have a more comprehensive workup, maybe get prescription, maybe even take the medication and go to the pharmacy before they leave town. Oftentimes I have one parent stay in the ER while the other one gets the prescription. In other words, patients who are from out of town, I try to be more comprehensive about my workup and make sure they have everything they need before they leave. Under the same circumstances, if the same type of patients with fever and unclear symptoms comes in, whose mom is very responsible, has a good relationship with her primary care and can follow up very easily, I may not engage in a comprehensive workup since I know those patients have where to go. So I adjust my workup and my care based on the patient's situation. Another good example is during the winter when we see a lot of patients with bronchiolitis. Very often I see a newborn with bronchiolitis who's what I call borderline for admission. His oxygen saturation is 92%, which is okay. He or she has some retractions, maybe some abdominal breathing. However, if the mom is very comfortable, this is not her first child, she knows what to do, and she has a good primary care, such a patient may be discharged. However, sometimes the mom is very young, it's her first baby, patient may or may not have good primary care, and under those circumstances, such a patient, in my opinion, should come in for observation. So again, I adjust my care based on the patient's situation. Medicine is an art, not a science. Another good example is the patient that comes in with asthma exacerbation. Patients with moderate asthma exacerbation, for example, have very different management based on their situation. And again, let me explain. Let's say I see a patient in moderate respiratory distress whose oxygen saturation is borderline. He or she are working hard to breathe, but it's not so bad. When I take the history, I learned that at home, mom ran out of medications and the patient has gotten no albuterol in the last day or 2 or 3. Such patients, in my experience, do very well in the pediatric emergency department since I give them a lot of medications, they have nothing in their system, and often those patients turn around very well. However, if the same patient comes to the pediatric emergency department and mom or dad are telling me they've been giving albuterol every 4 hours for the last 2 days and maybe even gave some steroids that they have left in the fridge, I'm much more worried. Here's a patient in front of me with moderate asthma exacerbation who has gotten a lot of medications at home, and despite those medications, he or she are in moderate distress. So I adjust my care based on the patient. That patient I will likely treat a lot more aggressively, probably with continuous albuterol, maybe IM epinephrine. Unlikely the patient is going to go home today, etc. So remember rule number 155. Adjust your care to the patient's situation. Maybe it's the social situation, maybe it's the medical situation. Every patient deserves personalized care if possible. And that is it for today, guys. Thank you very much for listening. Let's review what we learned. Rule number 153. Address the issues or the chief complaint like an ED doctor. Don't think like a diagnostician. Provide acute care, decide on the appropriate disposition, do whatever workup you need to do in the middle, but keep in mind you're not necessarily in the business of diagnosing the condition, but you are in the business of ruling out emergencies, urgencies, and life-threatening situations. Rule number 154. Pinpoint the syndrome if you can. Talk to the parents, consult whoever you need to consult, but if you can find out what specific syndrome the patient have, you might be able to find out and look up what complications he or she are at risk for. This way, when you address the chief complaint, you'll be able to rule out the possible complications for that patient and hopefully do the right thing and decide on the appropriate disposition. Rule number 155. Adjust your care to the patient. Some patients, although they have the same chief complaint as the patient before them, may need some workup because of their social situation or the follow-up is different than a patient that has good primary care and a responsible parent who has seen this before and been taking care of them for many years. So your care has to be adjusted based on the patient's situation, the medical situation, the social situation, the ability to follow up, etc. And that is it for today, guys. Thank you very much for listening to PEM Rules, and thank you for reading my article on EP Monthly. I appreciate the feedback. I appreciate the support. This is yet another excellent bass riff by Flea from the Red Hot Chili Peppers. It's called The Adventures of Rain Dance Maggie. Can't really get that title for the song. Great song nonetheless. Hope you like it.